Hello students, welcome to the session. We'll start with a case scenario. So it's a case of a 55-year-old male admitted to the hospital with complaint of severe pain in the knee area, and a small amount of pus discharge was exuding. A small amount of discharge was coming out from the ingrown hair. Okay. On physical examination, the local area was found to be red, warm, and tender. So, what is the clinical diagnosis? The clinical diagnosis here is the local area is red, warm, and tender with an indistinct border, and you have severe pain in that area, and at places small amount of pus is oozing out. So it's a case of cellulitis, and the causative agents of cellulitis are various agents. Most common agents are Staphylococcus aureus, Streptococcus pyogenes, and other pyogenic organisms, among which Staphylococcus aureus is one of the most common agent of skin and soft tissue infection. Okay, cellulitis is a type of skin and soft tissue infection. So, with this introduction, let us discuss Staphylococcus infection. The learning objective of this session include we will discuss various Staphylococcus aureus infections, its a virulence factor, pathogenesis, clinical manifestation, laboratory diagnosis, treatment, and drug resistance in Staphylococcus aureus. Then we will summarize the other Staphylococcus species infections, which are called as coagulase negative Staphylococcus infections. So, how common is Staphylococcal infections? Remember that Staphylococcus species are one of the most common organisms encountered in the clinical specimen. Okay, and Staphylococcus, how the name is been derived, staphylo and coccus. Staphylo is been derived from a Greek word. Okay, it was coined by Sir Alexander Augustine. He is a scientist who has coined the word Staphylococcus from a Greek word named Staphyli. Staphyli means what? It forms bunch of grapes. Okay, the reason is the gram staining appearance of Staphylococci are they appear in gram positive cocci, and the arrangement is in clusters. Okay, so they will be arranging in clusters. So the cluster of arrangement looks like a bunch of grapes clubbed together. Okay, they are present together. Hence the name Staphylo. And of course, why the name cocci? Because they are round shaped, they are berry shaped. Okay, or they are round shaped. Hence the word cocci. So this is a history of Staphylococcus. So Staphylococcus is, as I told you, one of the most common organism implicated in clinical specimen. They can be differentiated from another gram positive group of organism called Streptococci by performing a very important test called as catalase test. Staphylococcus are typically catalase positive, whereas Streptococci are typically catalase negative. Various Streptococci examples are, you have a Streptococcus, you have pneumococcus, you have enterococcus. All these are various type of Streptococci, and all are uniformly catalase negative. So catalase test can differentiate Staphylococci from Streptococci. Okay, the and one more difference is their gram stain appearance. Staphylococcus, I told you, they are typically gram positive cocci in cluster, whereas Streptococci are also gram positive cocci. They are arranged in chain or in pair. Streptococcus is arranged in chain, whereas pneumococcus and enterococcus, they are arranged in pair. The question is, why the gram stain appearance is like that? The reason is In Staphylococcus, it depends upon the cell division. Okay, the gram staining appearance is purely dependent upon the cell division. Staphylococcus, the cell divides in multiple plane. The Staphylococcus cells, they divide in a multiple plane, and the daughter cell, they remain attached to the parent cell. So that is why after the cell division, the daughter cell will be attaching to the parent cell, hence they appear in cluster. In compared to that, Streptococcus, the cell division occurs in single plane. Okay, the cell division occurs in single plane, and the daughter cell, if they are attached to each other, then they will be forming chain. If they will get separated, then they form pair. Okay, so this explains why Staphylococci are in cluster, because the cell division occurs in a multiple plane, and why Streptococci are in chain or pair, because the cell division occurs in a single plane, and if they get separated, they form a pair. If they will attach to the parent cell, they will form chain. Okay, so the test to differentiate Staphylococcus and Streptococcus will be the catalase test. Now, all Staphylococci are catalase positive. They can be differentiated based upon coagulase test into Staphylococcus aureus, which is coagulase positive, and other Staphylococcus species which are called as coagulase negative Staphylococcus. CONS is the abbreviation used for them. They are called as coagulase negative Staphylococcus. Why this classification is important? Because Staphylococcus species is the most pathogenic Staphylococcus species encountered in the clinical specimen, whereas other Staphylococcus species, that is coagulase negative staph, they are relatively less pathogenic. Many times they appear as skin commensals also. Okay, so with this, let us start. The most important Staphylococcus species, the most pathogenic species, Staphylococcus aureus. Okay, as I told you, it is the most virulent Staphylococcus species. It expresses several virulence factors which are not present in other Staphylococcus species, and this makes it most pathogenic than other Staphylococcus species. Okay, infections, it can cause widespread infection, though we are discussing Staphylococcus aureus under skin and soft tissue infection. So that is why you must know that it is the most common organism to cause skin and soft tissue infection. But at the same time, it can cause various systemic infection. It can cause various systemic infections starting from bacteremia, from UTI, from meningitis, pneumonia. So one end it can cause local infection, skin and soft tissue infection. The other end it can cause widespread multi-system infections. So it is one of the most common organisms encountered in clinical specimen. Gram staining we have discussed. They are arranged in clusters. They are spherical cocci around 1 micrometer in size, and they are arranged in cluster. Cultural property, they have classical cultural property. On nutrient agar, they typically produce golden yellow colonies. Okay, hence the word aureus. Why it is called as aureus? The aureus word is derived from the word, the meaning of aureus is gold, because it gives a golden yellow appearance of colony on the nutrient agar. Therefore, it is called as aureus. And of course, on blood agar, it is typically producing hemolytic colonies. Okay, especially beta hemolytic colonies on blood agar. So this is the introduction of Staphylococcus aureus. We will start with its virulence factor. Staphylococcus aureus can produce various virulence factors. Okay, the virulence factors can be classified into 4 categories: cell wall factors, toxins, and hemolysis, okay, and enzymes. So these are the four category of virulence factors produced by Staphylococcus aureus. We'll start with cell wall factors. Various cell wall associated factors. The first and the most important is peptidoglycan. Remember that Staphylococcus aureus is gram positive. So gram positive will have a thick peptidoglycan layer, and the peptidoglycan layer will confer rigidity to the organism. It confers rigidity to its cell wall, and it maintains the shape, and it can also induce inflammation. Okay, it is pyrogenic in nature. It can induce fever and inflammation. They say that it may have endotoxin like activity. It can induce inflammation. So the next virulence factor is teichoic acid. It is also an exclusive component of gram positive cell wall, and it helps in attachment. It also inhibits phagocytosis, inhibit opsonization. Opsonization is a process of enhanced phagocytosis. Okay, so apart from that, there are two important components which are exclusive feature of only Staphylococcus aureus cell wall. Okay, the first two what we discussed are cell wall and peptidoglycan. They are exclusive for all gram positive organism, whereas the clumping factor and protein A, these two are component of Staphylococcus aureus cell wall. Clumping factor is again, it is responsible for slide coagulase. It is exclusively present for it is exclusively present in Staphylococcus aureus, and it is responsible for slide coagulase, and clumping factor also helps in fibrinogen binding. It is called as a fibrinogen binding adhesion. It helps in binding to the fibrinogen. Similarly, a protein A, again it is exclusively for Staphylococcus aureus. It is expressed by around 90 to 99% strain of Staphylococcus aureus. So it is exclusive protein of Staphylococcus aureus. The function of protein A includes, it is anti-complementary, inhibits the complement. It is chemotactic in nature, and it also inhibits opsonization. Okay, so these are the various functions mediated by protein A. Protein A also helps in another important property which is called as coagglutination reaction. Coagglutination reaction is an exclusive property of protein A of Staphylococcus aureus. What happens? This is Staph aureus. This is the protein A of Staph aureus. Protein A of Staph aureus has a property of it can bind to Fc portion of any IgG antibody. Okay, it can bind to Fc portion of any IgG antibody, and this property can be exploited to detect antigens of various organisms in clinical specimen by binding to its respective antibodies to protein A of Staphylococcus aureus. Okay, so this is obsolete now. This coagglutination reaction is not in use. It is obsolete. However, I can just tell you the principle of this, what was used before. So the principle of this test include the Staphylococcus aureus acts as a carrier molecule. How it acts as a carrier molecule? Because of its protein A molecule, which can be used to bind to antibodies by binding to the Fc portion of various antibodies. So, for example, if you want to detect Haemophilus antigen in CSF specimen of meningitis patient, then what you do is you can coat Haemophilus antibodies. You can coat Haemophilus antibody on Staphylococcus aureus, and such cells, such Staphylococcus aureus cells coated with Haemophilus antibodies, you can add a drop of CSF specimen. If it contains Haemophilus antigens, then antigens will go and bind, and antigen antibody reaction can take place on the surface of Staphylococcus aureus. So Staph aureus acts as a carrier molecule here, and such reaction is called as coagglutinating reaction. Now of course this test is obsolete because now we have better carrier molecule like latex particle. Okay, so this is called as protein A. So there are four important cell wall associated virulence factor: peptidoglycan, teichoic acid, then your protein A, and clumping factor or fibrinogen binding adhesion. So these are the cell wall associated effectors. Now we'll discuss about the toxins. The first toxin is membrane active toxin. Okay, the first toxin is membrane active toxin. The membrane active toxin, as the name says, it will act on the membrane and it will form pores over the membrane that leads to lysis of the cell. So this is the function of most of the membrane active toxin. They will act on the membrane of various cells. The classical examples of membrane active toxin include hemolysin. Hemolysins, Staphylococcus aureus can produce four types of hemolysins: alpha hemolysin, beta, gamma, and delta. So these are the four types of hemolysins. They will act on RBCs to produce lysis. Okay, that is why they are called as hemolysin, because the function of these toxins include they cause hemolysis by acting on the RBCs. Apart from that, they are dermatonecrotic, they are cytotoxic, they can act on the cells of various they can act on the cell membranes of various cells, so they are cytotoxic, and they are also leukocidal because they will act on WBCs. They will cause lysis of the WBC. So these are the other functions of hemolysis. Okay, then one more type of membrane active toxin is called as PV toxin, or it is named after the scientist name Panton Valentine toxin, or it is also called as leukocidin. Okay, PV toxin or Panton Valentine toxin or leukocidin. So this is also a type of membrane active toxin. They say that it also can act on leukocytes. It can cause lysis of WBCs, leukocytes. It is leukocidal in nature. It can also act on macrophages and RBCs. So these are the various cells the PV toxin can act. Okay, the PV toxin is often similar to gamma hemolysin. Both, they say that the functions of both are overlapping to each other and they often work synergistically. Okay, the PV toxin and gamma hemolysin, they often work together synergistically, and therefore these two toxins are together called as synergohymenotropic toxin, which is again a very important MCQ for you. PV toxin and gamma hemolysin are together called as synergohymenotropic toxin because they act together. So these are the various membrane active toxin: alpha, beta, gamma, delta hemolysins and PV toxin. All are called as membrane active toxins. Now we'll discuss about other toxin. The second toxin is epidermolytic or exfoliative toxin. As the name says, it acts on the skin and it causes epidermolysis. Epidermolysis or exfoliation. Exfoliation means the skin will come out. Exfoliation. You can see exfoliation. The skin comes out, peels out of the body, and this particular sign is called as Nikolsky sign. Nikolsky sign means it is a sign where the skin comes out, peels off of the body, and is called as Nikolsky sign. Okay, so this is the primary function of epidermolytic toxin, and the disease what it produces is called as scalded skin syndrome. Okay, epidermolytic toxin or exfoliative toxin, it is responsible for scalded skin syndrome, where skin usually comes out pills of the body, and this sometimes occurs in milder form. It can also occur in more invasive form. The milder forms are called as bullous impetigo and pemphigus neonatalum. Pemphigus neonatalum occurs in neonates. Bullous impetigo may be occurring in adult. So these two are milder form of the disease, whereas the more severe form of the disease is called as Rhetus syndrome in newborn, and it is one of the agent of toxic epidermal necrosis in adult. Okay, so you can see here, this is a newborn scalded skin syndrome, which is often called as Rhetus syndrome. It is a more invasive form of disease, is a more severe form of the disease called as Rhetus syndrome, and in adult it can induce toxic epidermal necrosis. So these are the various varieties of scalded skin syndrome in different age groups. So this is more common in children, especially in the neonatal age group, than in adult age group. Okay, where the skin peels off, which is called as a positive Nikolsky sign. Okay, so now next toxin is the third toxin is enterotoxin. Staphylococcal enterotoxin has a characteristic property of being preformed in nature. Okay, so it causes food poisoning. It causes food poisoning which has an incubation period of 1 to 6 hours. So it is one of the food poisoning where the clinical manifestation will appear in 1 to 6 hour of food consumption. Okay, why it happens so early? The reason is it is an example of preformed toxin. The toxins are already formed in the food, so when you consume the food, you are directly consuming the toxin, which can immediately produce its manifestation. Mostly it presents as nausea and vomiting. Okay, the most common food associated are dairy foods, various dairy fruit products, milk based fruit products. Other than that, even meat, fish and other food items also can transmit the toxins, but the dairy products, the milk products are the most common food to be associated. Remember this staphylococcal food poisoning we will be discussing in detail under food poisoning chapter in gastrointestinal infective syndrome. Okay, remember that staphylococcal enterotoxin has got various serotypes. It has got around 15 serotypes, among which type A is the most common toxin to cause food poisoning, whereas type F is not an enterotoxin. It doesn't cause food poisoning. In fact it causes another syndrome called as toxic shock syndrome, and hence this toxin is renamed as toxic shock syndrome toxin. So with this we will discuss the next toxin and the most virulent toxin of Staphylococcus aureus, called as toxic shock syndrome toxin. It is nothing but it is enterotoxin type F. Toxic shock syndrome toxin is nothing but it is enterotoxin type F, and here this disease occurs because of various risk factors. The most important risk factor is use of vaginal tampons by the menstruating females. Okay, so this used to be a common practice to use the vaginal tampons by the menstruating females, and this is the most important risk factor which promote toxic shock syndrome. They say that the Staph aureus present in the vaginal flora, it will start secreting the toxin staphylococcal toxic shock or syndrome toxin or enterotoxin F, and this toxin is an example of superantigen. This toxin is an example of superantigen. What is superantigen? We will discuss in our immunology session. Just you remember that the superantigens have a property of directly activating the T cells by attaching to the variable beta region of T cell receptor. Okay, and they do not need antigen presenting cell. Okay, the detail I am not discussing here. Usually you would have learnt in your antigen chapter in the immunology section that whenever an antigen comes, first it has to be processed by antigen presenting cell. Whenever an antigen comes, first it has to be processed by antigen presenting cell, which will present to the which will present and which will process the antigen and will present to a T helper cell. T helper cell, usually the antigen will bind on the antigen binding cleft of the T helper cell. Superantigens are a little different. They do not need to be processed by antigen presenting cell. In fact, they will bypass the antigen presenting cell and they can directly activate the T cells by binding not to the antigen peptide group, but they will bind to a special site called as the variable beta region of T cell receptor, and such binding is non-specific that leads to massive release of cytokine. Remember that such binding is non-specific. You will have non-specific activation of T cell, and that leads to massive release of cytokines. And the massive release of cytokine is responsible for various clinical manifestations seen in toxic shock syndrome. So this is the pathogenesis. Now we will discuss the clinical manifestation. Remember that the clinical manifestation of toxic shock syndrome are all related to massive cytokine influx. So the release of cytokine will cause various manifestations. You will have multi-organ dysfunction. So it is characterized by, they say that the clinical definition of toxic shock syndrome is characterized by, you will have fever, you will have hypotension, you will have desquamation. Desquamation will be like scalded skin syndrome, and you will have multi-organ involvement. At least 3 or more organs will be involved. The common organs are kidney, lung, GIT, and various other organs. Okay, various organs will be involved, but at least 3 or more organs to be involved to satisfy the criteria. So there are 4 criteria. You will have fever, hypotension, desquamation, and at least multi-organ failure. Okay, so these are the clinical manifestation. Diagnosis wise, remember that it is diagnosed by a detection of toxic shock syndrome toxin by, you can conduct various enzyme immunoassays to detect the toxin in the clinical specimen. You can also detect the gene of toxic shock syndrome toxin by performing PCR. Cultures will usually be negative. Okay, cultures are usually negative for Staphylococcus aureus because organism doesn't invade; it will remain at the vaginal site, and only the toxin will be liberated, and the toxin will go to various sites and will cause manifestations. Don't think that vaginal tampons are the only risk factor, because now they say that the disease is common even in males. It is seen even in females not using tampons. Okay, so toxic shock syndrome is now widespread in nature. It is not confined to the vaginal tampon users. It can also be seen in other group of individuals also. Okay, so now coming to the treatment, remember that symptomatic management is the mainstay of treatment. You have to correct the hypotension, correction of fluid loss, correction of hypotension. You have to give vasopressor. Of course, antibiotics are required, and here antibiotic of choice is clindamycin plus vancomycin. Vancomycin will act against the organism, whereas clindamycin will suppress the toxin synthesis because it is a protein synthesis inhibitor. So it will typically suppress the toxin production. Okay. So let us discuss the pathogenesis of Staphylococcus aureus infections. The first event which occurs in pathogenesis is colonization. Most of us will carry Staphylococcus aureus as a commensal in our skin. Okay, so at least 20 to 30% of individuals, they carry Staphylococcus aureus as a skin commensal. The most common site of commensal being the anterior nares. This is the most common site where Staph aureus colonizes. Other sites include the various skin sources like your axilla, perineal skin region, and other areas of skin. Okay, so following the colonization, the next event is introduction into the tissue. The Staph aureus has to be introduced into the tissues for the pathogenesis to take place. So the introduction to various tissues, this occurs only when you have a breach in the skin, because just presence of Staph aureus in the skin as a commensal doesn't equate to infection. You should be able to introduce the organism into the skin. That may happen through the instrumentation. Okay, either you perform a certain instrumentation. Most important is central line insertion. A central line we will be inserting into the subclavian vein for the various medical purposes, or even the peripheral line insertion, a venflum insertion into the vein. All these will carry Staph aureus into the bloodstream. So central line insertion, or even any minor abrasions into the skin, that also will cause Staph aureus to invade inside, or a surgical site infection, because Staphylococcus aureus can invade into the body through the surgical incision. So incisional sites are a potential source of Staphylococcus aureus infection. Okay, so these are the various methods through which the organism will be introduced into the body. Once it is introduced into the body, the next event is invasion. Organism will be invading throughout the body. That happens by elaboration of various virulence factors. Staphylococcus aureus can produce various enzymes like lipases, phosphatases. All these will break down the tissues so that the Staph aureus can be invading inside. The next event is evasion of host defense mechanisms. So once Staphylococcus aureus will be present inside the body, it should be able to evade the host defense mechanism, and that happens through, again, through the various virulence factors. You know that Staphylococcus aureus virulence factors are antiphagocytic in nature. They will inhibit the leukocyte migration, as well as they will be able to survive intracellularly. Intracellular survival of the organism is possible when the Staphylococcus aureus will be switching over to smaller colony variants. Okay, the Staphylococcus aureus may switch over to small colonies. These variants are called as small colony variants. So as a result of which it can be surviving inside the host cells. So intracellular survival. And antiphagocytic property is a very important reason for the evading the host immune mechanism. Okay, so once the organism is able to survive in the host, it is able to evade the host immune response. Next event is the metastatic spread of the organism to various organs. Staph aureus will invade the bloodstream. That leads to bacteremia, and from blood it can go to various organs such as meninges, urinary tract, and various other organs. So it can cause various invasive infections. So this is the pathogenic event which take place. Now moving on to the clinical manifestations. Staphylococcus aureus can produce widespread infections, the most important of which is skin and soft tissue infection. Okay, it is the most common organism to cause skin and soft tissue infection. Okay, the various skin and soft tissue infection include, it can infect the hair follicles to cause folliculitis, infection of hair follicle to cause folliculitis. There may be pus formation in the region of follicles, that is called as furuncle. Furuncle is a condition where you will have pus formation in the follicle region. Few of the folliculitis will be coalesced to form carbuncle. Carbuncle is nothing but the furuncles will join together to form a larger area of infection called as carbuncle. So all these three are infection of hair follicle. Okay, it starts with a folliculitis, single infection of a hair follicle. Hair follicle infection associated with the pus formation is called as furuncle, and few of the furuncles will coalesce, will join together to form a carbuncle. Okay, so these are the hair follicle infections. Other than that, you have abscess formation. Abscess may break down to form ulcers. Then you will have impetigo. Impetigo is nothing but it is usually seen in children, where you will have red sores over the mouth area. Okay, surrounded by erythema. Okay, and it is described as honey color crust. Honey color crust formation called as impetigo. Okay, it is again a cutaneous infection. Next is, you may have a cellulitis. That is, the infection may spread to dermis and the subcutaneous tissue. Spreading of the infection to dermis and subcutaneous tissue called as cellulitis. Next is, it may involve the fascia to cause necrotizing fasciitis. Okay, involvement of the fascial layer called as necrotizing of fasciitis. Streptococcus and Staphylococcus are the common cause. Okay, so other than that, there are various other skin and soft tissue infection Staphylococcus aureus may produce. Those include surgical site infection, surgical site wound infection. Please remember that Staph aureus is one of the most common organism to cause a surgical site infection. I told you that they will be skin flora. So if you have any breach, incisional breach, then the organism may spread inside to cause surgical site infection. Then infection of the apocrine gland, which is called as hidradenitis suppurativa. Okay, infection of the apocrine gland, especially in the axillary region. Other infections include breast abscess and mastitis. Staphylococcus aureus is the most common organism to cause infection of breast. Mastitis and breast abscess can be produced. Next is a mycetoma-like condition called as botryomycosis. Botryomycosis is a mycetoma-like condition caused by Staphylococcus aureus. So these are the entire exhaustive list of the skin and soft tissue infections caused by Staphylococcus aureus, and then we will discuss about the next infections. Next is musculoskeletal infections. Staphylococcus aureus can produce various musculoskeletal infections. In fact, it is the most common organism to cause osteomyelitis, septic arthritis. You can see here septic arthritis, joint infection. Okay. Next is a muscle infection called as pyomyositis. Pus formation in the muscle region called as pyomyositis. Staphylococcus aureus is the most common infection to cause pyomyositis. Abscess near the iliopsoas muscle called as psoas abscess. Okay, it is a retroperitoneal collection of the pus near the iliopsoas muscle. This is called as psoas abscess. Okay. So these are the various musculoskeletal infections caused by Staphylococcus aureus. Moving on to the respiratory tract infections, Staphylococcus aureus can cause pneumonia. Both community acquired pneumonia and hospital acquired pneumonia Staph aureus can cause. Most of the pneumonia may occur secondary to viral infection. Okay, so please remember it may cause secondary pneumonia following viral infection such as influenza or COVID-19 infection. After that, Staphylococcus aureus may cause secondary infection. So this is called as a pneumonia following primarily a viral infection. Okay. Then Staphylococcus aureus can cause pneumatocyst. Pneumatocyst is nothing but it is a cavity formation inside the lungs which is due to Staphylococcus aureus. Okay. Saggy, thin walled cavity formation in lungs. Okay. It may happen in the neonates and children more commonly. So this is called as pneumatocyst. Staphylococcal pneumonia is quite common in infant. Okay, it is one of the important cause of infant pneumonia. Okay, so these are the widespread respiratory tract infections. Next is bloodstream infection. Staphylococcus aureus is one of the most common organisms to cause bloodstream infection. It can cause sepsis, endocarditis, and catheter related bloodstream infection. Catheter related, that is a central line related bloodstream infection against Staph aureus is the most common agent. Endocarditis, remember Staphylococcus aureus is the commonest agent of endocarditis. It can cause native valve endocarditis, prosthetic valve endocarditis, right-sided infective endocarditis in IV drug abuses. IV drug abuses, it can cause right-sided endocarditis. Overall, the most common cause of endocarditis is nothing other than Staphylococcus aureus. So it is a very important pathogen of bloodstream. Okay. Next is it can cause various urinary tract infection also. Staph aureus, though it is less common than gram-negative infection, it is one of the most important cause of UTI. Okay. Next is what are the various toxin-mediated staphylococcal infections. I told you Staph aureus will produce three important toxins called as epidermolytic toxin, enterotoxin, and toxic shock syndrome toxin. Epidermolytic toxin, it can cause scalded skin syndrome. This we have already discussed earlier. Enterotoxin, it can cause food poisoning, especially following the contaminated milk products ingestion. Toxic shock syndrome toxin is responsible for an important disease called as toxic shock syndrome. Okay, so these are the various toxin related diseases by Staphylococcus aureus. Now we will discuss what are the important diseases associated with community acquired MRSA. MRSA is methicillin resistant Staphylococcus aureus. It is a category of Staphylococcus aureus which is resistant to the methicillin and other beta-lactam drug. We will discuss about MRSA a little later. Now I will just tell you the infections associated with community acquired MRSA. MRSA strains are of two types, hospital acquired and community acquired. The community acquired MRSA strains are more virulent. They are more virulent. They are associated with various widespread infections such as necrotizing fasciitis, sepsis with Waterhouse Friderichsen syndrome. This Waterhouse Friderichsen syndrome is usually more common in meningococcal infection, but it can also be seen occasionally with MRSA, especially community associated MRSA. Okay. Other than that, necrotizing pneumonia. Okay. So remember that community associated MRSA strains are more virulent than hospital acquired strains. They can cause higher frequency of necrotizing of ascites, necrotizing pneumonia and sepsis, especially with Waterhouse Friderichsen syndrome, which is otherwise a usual complication of meningococcal infection. So these are the various infections associated with CAMRS. So now we have done with the clinical manifestations of Staphylococcus aureus infections. Now we will see the epidemiology. So you know that Staphylococcus aureus can colonize human skin. Okay, it is a normal human flora, especially various skin. I told you that anterior nares is the most common site, followed by your axillary skin, perineal skin region. Okay, oropharynx also, Staphylococcus aureus may be colonizing on oropharynx. The rate of colonization may vary depending upon the risk factors associated. So remember that the higher rate of colonization has been reported from diabetic patients, individuals with skin damage, individual with skin lesions. If you have skin lesion, other various other dermatological lesions, then the skin damage will promote Staphylococcus aureus colonization. Okay, also a patient undergoing hemodialysis, IV drug abuses. Okay, so these are the various risk factors where Staphylococcus aureus colonization risk is more. Okay, so now we'll see some of the MCQs. The first question is, scalded skin syndrome is mediated by, it is caused by Staphylococcus aureus, and the toxin associated is epidermolytic toxin, or also called as exfoliative toxin. The next question, toxic shock syndrome. All are true except, remember it is a superantigen which can stimulate the T cell to cause a massive release of cytokine, which is called as cytokine storm. And the toxin synthesis, the toxic shock syndrome toxin synthesis can be suppressed by giving clindamycin, because it will inhibit the protein synthesis. Please remember, though vaginal tampon is the important risk factor, but it doesn't mean that it is always associated with the vaginal tampons. Toxic shock syndrome can occur without association with vaginal tampons also. So only associated with use of tampon will be a wrong statement. Okay. So now we will move on to the laboratory diagnosis of Staphylococcus aureus infection. So first is specimen collection. Okay. The specimen collection depends upon the site of infection. For skin and soft tissue infection, you will take wound swab from deeper pockets or even pus specimen. Okay, so these are the appropriate specimen for skin and soft tissue infection. If you have a bacteremia, you can take blood. If you have a UTI, then you can take urine. For respiratory tract infection, you can take sputum or endotracheal aspirate and other respiratory specimens. So it all depends upon the site of infection. If you have osteomyelitis, again you can take blood. Septic arthritis, synovial fluid can be taken. So these are the various specimens. So after you collect the specimen, the first thing what you do is direct microscopy. So remember, when you perform a direct microscopy, what you will see is pus cells with gram-positive cocci arranged in cluster. You can see here plenty of pus cells. This is a pus cell. Plenty of pus cells with gram-positive cocci arranged in cluster is a typical finding of Staphylococcus aureus in direct microscopy. After that, those specimens what you have collected, can be subjected to a culture. The important culture media include a nutrient agar where Staphylococcus aureus will produce golden yellow colonies. Okay, a golden yellow colonies on nutrient agar, hence the name Aureus. Blood agar, it will produce golden yellow. It will look golden yellow in blood agar also, with beta hemolytic colony, complete hemolysis, beta hemolytic colonies on blood agar, complete hemolysis. Okay, so if you will get a zone of hemolysis surrounding the staphylococcal colonies. So this is called as beta hemolytic colonies, and the colonies are little larger than streptococcal colony. They say that streptococcal colonies are pinpoint, whereas staphylococcal colonies are pinhead shaped. So pinhead shaped colony, that is a little larger colony, around 1 mm in size or even a little larger, and typically they are golden yellow with beta hemolysis in the surrounding. So this is this is a very important picture, is a blood agar showing the colonies of Staphylococcus aureus. So you can also go for a selective medium. The important selective medium is mannitol salt agar. So this is a picture of a mannitol salt agar where you can demonstrate yellow color fermenting colonies of mannitol fermenting colonies of Staphylococcus aureus. Okay, so these are the culture media, among which blood agar is the most important media used for Staphylococcus aureus for isolation from the clinical specimen. Suppose if you take blood specimen, then blood specimen should be directly inoculated into blood culture bottle like Bacteolate or any other blood culture bottles. Okay, blood specimen alone you cannot do a direct subculture onto the blood agar. First you have to enrich them into inoculating into blood culture bottles. After that, once they flag positive, they can be subcultured onto the blood agar. Okay, so these are the various clinical specimen. After the colony is grown on blood agar, when you get beta hemolytic pinhead shaped golden yellow colonies on blood agar, do a gram stain, because the culture smear will reveal gram positive cocci in cluster. That will give you another clue that it is staphylococcal colonies, because gram positive cocci in cluster is a property of staphylococci in general. Okay, and of course they are non-motile. So if you do a motility testing by hanging drop, you will find that they are non-motile. After you do a culture smear where you will reveal gram positive cocci in cluster, you have to further differentiate it from streptococcus. Of course, gram staining will differentiate from streptococcus, because streptococci are in chain or pair, whereas staphylococci are in cluster. But the most important test to do differentiate staphylococcus from streptococcus is performing a catalase test. So the same colony, if you inoculate the same colony, if you take a slide, put a drop of hydrogen peroxide over the colony. So you put a drop of hydrogen peroxide over a slide, take one colony and inoculate into the mix with the hydrogen peroxide, then bubbles will appear. So this is called as a positive catalase test. This is characteristic feature of Staphylococcus aureus, whereas streptococci are catalase negative. So this is a characteristic feature of not Staphylococcus aureus alone, all Staphylococcus. All Staphylococci are catalase positive, which differentiate them from streptococci, which are catalase negative. So after you differentiate staph and strep can be differentiated. I told you first is by gram stain, gram positive cocci in cluster versus gram positive cocci in chain, then catalase positive, catalase negative. So these are the point of difference between staphylo and streptococcal colony. So after you differentiate, when you know that it is staphylococcus, now the question is, it is staph aureus or it is other staphylococcus species which are called as coagulase negative staph. That differentiation can be done by performing various biochemical tests. The most important is coagulase test. So this is a picture of coagulase test, Coagulase tests are of two types, tube coagulase and slide coagulase. The picture which is focused here is tube coagulase. So take a drop of plasma, take a broth of plasma in a tube, mix a colony of Staphylococcus aureus and you incubate this for 4 to 6 hour incubation. Then what you will see is the plasma will be clotted. It will become firm, the plasma will be clotted. So the presence of clotting indicates that coagulase test is positive, and it is positive for Staphylococcus aureus, whereas all other Staphylococcus species are called as coagulase negative Staphylococcus, or abbreviated as cons, where the plasma doesn't clot. Okay, so clotting of the plasma indicate it is positive Staph aureus. If the medium remains liquid, if it doesn't clot, then it is called as coagulase negative, is a feature of other Staphylococcus species. So this is tube coagulase. Now we will move on to another coagulase test called a slide coagulase test. It is also called as clumping factor test, because here you are detecting the ability of Staphylococcus aureus to clump, to form clumps when mixed with plasma, and it is due to clumping factor of Staphylococcus aureus. So how it is done? Take a slide, over a slide put a drop of plasma, then so you put a drop of plasma, then you add a colony of Staphylococcus aureus and you mix the Staph aureus colony with the drop of plasma. Then you rotate the slide for some time and you will see that the Staph aureus colonies will form clumps. So formation of clumps indicate the test is positive, and it is typical of Staph aureus, whereas for other Staphylococcus species, they will remain as a milky white suspension. They will remain as a milky white liquid suspension which will not break into clumps. Okay, so no clump indicates negative, that is other Staphylococcus species. If formation of clumps indicate positive, that is Staphylococcus species. So I repeat, the Staphylococcus aureus can be differentiated from other Staphylococcus species which are called as coagulase negative Staphylococci by performing coagulase test, which is of two types, tube coagulase and slide coagulase. One more important test which can be done to differentiate is called as protein A detection. I have told you that protein A is a component in the cell wall of specific for Staphylococcus aureus. It will be positive for Staphylococcus aureus, where it will not be seen in other Staphylococcus species. So a latex agglutination tests are available. Latex agglutination tests are available for detection of protein A of Staph aureus. So this test is positive for aureus but will be negative for coagulase negative Staphylococci. Okay, so these are the point of differences. You should also know that what we have discussed now are the biochemical identification tests. You can also go for various automated system for identification. The classical example is Vitek, okay, and also Malditov. This is a picture of Malditov. The previous one is a picture of Vitek. These are the two, especially Malditov is the most important automated identification system for bacterial identification. These systems can be used for Staphylococcus aureus identification. Then you can perform antimicrobial susceptibility test. It is performed on a special medium called as Muller-Hinton agar by using disc diffusion test. Okay, so disc diffusion test can be performed on Muller-Hinton agar for antibiotic susceptibility test. This is the conventional antibiotic susceptibility test method. You can also use Vitek as a automated, conventionally by disc diffusion. You can also go for automated MIC based detection method. Example is Vitek. Okay, so the same Vitek equipment you can use for identification. You can also use for antibiotic susceptibility testing by MIC based detection method. So these are the methods for antibiotic susceptibility testing for Staphylococcus aureus. We will see some MCQs now. The all of the following are used for differentiating Staph aureus from other Staphylococcus species except remember that catalase test is used for differentiating Staph versus Streptococcus. It is positive for all Staphylococcus species. So it cannot differentiate Staph aureus versus other Staphylococcus species. Whereas it is the coagulase test, protein A detection, golden yellow beta hemolytic colonies on blood agar, all these are positive for Staphylococcus aureus, whereas they are negative for other Staphylococcus species. Now we will see the treatment of Staphylococcus aureus infection. Staphylococcus aureus infection treatment is purely based on the susceptibility. You have to know that these strains are MRSA strain or MSSA strain. MRSA strains for methicillin resistant Staphylococcus aureus. These strains are resistant to all beta lactam antibiotic, whereas MSSA strain stands for methicillin susceptible Staphylococcus aureus. So these strains will be susceptible to various beta-lactam antibiotics. So the detail of MRSA we will discuss in the subsequent slides. Now for the treatment purpose, you remember that if the susceptibility or results says that it is susceptible to penicillin, which is very rare because 90% of Staph aureus are resistant to penicillin, but 10% may be susceptible. So if the susceptibility result says that they are susceptible to penicillin, then you can give penicillin G as the treatment of choice. But this option is very limited because I told you that 90% of Staphylococcus aureus are resistant to penicillin. If the susceptibility report says that it is methicillin sensitive Staph aureus, that means you can give anti-staphylococcal beta-lactams. Anti-staphylococcal penicillins can be given. The classical example is cloxacillin, oxacillin, dicloxacillin, flucloxacillin and nafacillin. So these are the exhaustive list of anti-staphylococcal penicillin. They are the drug of choice if the isolate is methicillin susceptible Staph aureus. So please remember, for methicillin resistant Staph aureus, the drug of choice is vancomycin, because methicillin resistant Staph aureus are resistant to all beta-lactam antibiotic including anti-staphylococcal penicillin, and there the drug of choice is vancomycin. I want to add one more point here. If it is methicillin sensitive Staph aureus, then please do not give vancomycin, because vancomycin is an inferior drug than anti-staphylococcal penicillins for Staph aureus. So if susceptible, then always anti-staphylococcal penicillin like cloxacillin are the drug of choice. If only when they are resistant, that is in case of MRSA, you do not have any other option. That is why vancomycin is the drug of choice in that situation. Okay, empirically, you what antibiotic to start, that also depends upon the local MRSA prevalence rate. If your local MRSA rate is high, more than 10%, then you can start vancomycin as the empirical treatment. You can de-escalate if the susceptibility report says it is MSSA. If the local MRSA rate says that it is low, less than 10%, then you can start anti-staphylococcal penicillin like cloxacillin as the first line empirical therapy. If the result says it is MSSA, then you can continue the same antibiotic. If it says MRSA, then you can switch over to vancomycin. So this is a strategy used. Empirical therapy strategy is purely based upon the local MRSA rate. Okay. So now we will discuss what are the other treatment options available for skin and soft tissue infection. For MSSA, you can give dicloxacillin or flucloxacillin as a drug of choice, and cephalosporin of choice for MSSA infection. Cephalosporin is a first line cephalosporin antibiotic which is excellent for MSSA. If you have MRSA and if it is a skin and soft tissue infection, then alternate to vancomycin include clindamycin, cotrimoxazole, okay, doxycycline. All these are alternate drug which can be given, and linezolid can be used as a reserve drug. If these antibiotic like clindamycin, cotrimoxazole will be resistant, then for skin and soft tissue infection, linezolid can be given for MRSA infection. Okay, so these are the various options available for MRSA infection. Don't think that vancomycin is the only option. There are many other drugs which the non-beta lactam drug which may be effective. So you have to see what system is involved, and accordingly antibiotic need to be given. For example, linezolid has a better action on skin and soft tissue, whereas vancomycin is better for sepsis and bloodstream infection. Okay, so now we will see drug resistance in Staphylococcus aureus. Remember that the beta-lactam drug resistance, the drug resistance to a beta-lactam group of antibiotic may be of two types, either by production of beta-lactamase enzyme. This is shown by 90% of strains of Staph aureus, and they will be resistant to penicillin G. Okay, and this beta lactam resistance, that is beta lactamase enzyme production, is coded by plasmids, and this can be transformed from one Staph aureus to other Staph aureus by transduction. So please remember, the plasmid coded resistance is by beta lactamase enzyme. So the beta lactamase enzyme production is by plasmid coated. It is shown by 90% of Staph aureus, and they will be resistant to penicillin G. In contrast, another mode of resistance to beta lactam drug, which is called as by penicillin binding protein, which is caused by alteration of penicillin binding protein, and this is expressed by the strains of Staph aureus called as MRSA. So please remember the two type of beta lactam drug resistance. One is by production of beta lactamase enzyme, which is shown by 90% of Staph aureus strains. This is coded by plasmid, transformed from one cell to other cell by transduction, and they will be resistant only to penicillin, but they will be susceptible to cloxacillin and other anti-staphylococcal penicillins. Whereas MRSA is a type of Staph aureus strains which may be around 20 to 30% of Staph aureus are MRSA, and this is due to a alteration of penicillin binding protein. Let us discuss MRSA in detail. As I told you, it is mediated by a gene called as McA gene. MRSA is mediated by a chromosomally located gene called as mecazin, and this mecazin, what it does is it alters penicillin binding protein to penicillin binding protein 2A. So you know that penicillin binding protein is a protein present on the cell wall of various organisms including Staphylococcus aureus, and most of the beta lactam antibiotic, they bind to this protein. Why it is called as penicillin binding protein? Because it is a site of attachment of the beta lactam group of antibiotic. So the beta lactam group of antibiotic, they bind to this protein and they inhibit the this protein, and thereby they will inhibit the cell wall synthesis. So penicillin binding protein is a normal protein required for cell wall synthesis of Staph aureus and any other organisms. Many other organisms, they will have a penicillin binding protein as a component in their cell wall, and that will help in synthesis of the cell wall. Beta-lactam group of drug, how they work, how they destroy the organism. The beta-lactam group of drug, they will kill the organism by binding to the penicillin binding protein, and thereby they inhibit this protein, thereby they will inhibit the cell wall synthesis. So this is a normal mechanism by any uh, any organisms, how the beta-lactam antibiotic will work. What happens in MRSA? In MRSA, the penicillin binding protein gets altered to penicillin binding protein 2A by a gene called as mecazin, and this altered protein has got less affinity for beta lactam drug. Therefore, the beta lactam drug, they do not go and bind to this protein, and therefore they cannot act on Staphylococcus aureus. That is how the organism will become resistant to the beta lactam drug. So remember, MRSA is coded by mecazin. Mecazin alters the penicillin binding protein into penicillin binding protein 2A, and penicillin binding protein, which is a normal protein of the organism which helps in cell wall synthesis, is also the site for beta lactam drug to act and inhibit this protein, and thereby inhibiting the cell wall synthesis. In MRSA, penicillin binding protein gets altered, and this altered protein has less affinity for beta lactam antibiotics. So the beta lactam drugs cannot go and bind. As a result, the organism will become resistant to beta lactam drug. So here I want to say you one important fact, that MRSA is a misnomer because it was first reported for methicillin, hence they have named it as methicillin resistant Staph aureus, but actually MRSA strains are resistant to all beta lactam antibiotic, because the penicillin binding protein gets altered, which is a target site of all beta lactam. So in general, all beta lactam antibiotics the organism will become resistant to. Of course, there are some exceptions. Now there are something called as fifth generation cephalosporin. Fifth generation cephalosporin like ceftibiprole, and except the fifth generation cephalosporin like ceftobiprole, the organism, the MRSA strains are resistant to all beta lactam antibiotic. Okay, only fifth generation cephalosporin, they still remain active for Staphylococcus. They still remain active for MRSA strains. Okay, so now we will discuss about the risk factors. There are some risk factors which will promote there are some risk factors which will promote MRSA colonization, include poor hygienic condition, close contact, okay, individuals with damaged skin. So the risk factor for Staph aureus colonization are also the risk factor for MRSA colonization. Okay, so MRSA will be colonizing on those individuals who are having poor hygiene. They will have close contact to the other MRSA carriers, as well as if they have a damaged skin. There are two type of MRSA. One is called as community associated, other one is called as hospital associated. There are some differences. The community associated MRSAs are typically mediated by a mecazin type 4, 5 and 6. Among this, type 4 is very important, whereas the lower type like 1, 2, 3 mecagin subtypes, they are responsible for HA-MRSA. Community acquired MRSA are typically, they are less drug resistant, however they are more virulent and they express various toxins. The most important toxin is PV toxin. PV toxin, that is a Panton Valentine toxin, is more expressed by community associated MRSA strains, and they are responsible for various infections such as necrotizing fasciitis, necrotizing pneumonia and other infections. So CA-MRSA strains appear to be more virulent than hospital acquired MRSA strain because they express more virulent toxin like PB toxin. However, they are less drug resistant. In contrast, the hospital strain of MRSA are multi-drug resistant, but they are less virulent. They will have lower expression of PV toxin, and the infection range of hospital acquired MRSA strains include various perioperative surgical site infection, surgical site infections, and they will cause various hospital outbreaks of infections. However, the more serious infection like necrotizing fasciitis, necrotizing pneumonia, all these are more common for community associated MRSA strain. However, I want to tell you one important fact is now the distinction between CA MRSA and hospital acquired MRSA is fading over a period of time. Now many CA MRSA strains, they behave like HA strains. Many HA strains are also behaving like the community strains. So now the properties are quite overlapping, but still for the exam point of view, you should know the differences between CA MRSA and HA MRSA. Okay, so now we will see how will you detect MRSA and how will you treat. So the detection of MRSA is by performing disc diffusion test, and a very important disc we use called a cefoxitin disc. This is cefoxitin disc is used for detection of MRSA. Other than that, you can also go for MEK gene detection. MEK gene detection by performing PCR. Oxacillin MIC detection also is one of the antibiotic which can be used for MRSA detection. Okay, so cefoxitin and oxacillin antibiotics. Oxacillin by MIC detection method, cefoxitin by both disc and MIC detection method, or mechanism detection method. So these are the method to detect MRSA. Treatment of MRSA, I told you that vancomycin is the drug of choice. Of course, you can give any other non-beta lactam antibiotic, like for example linezolid, daptomycin, okay, quinoprustin, dalfopristin, these are streptogarmins. Okay, these are streptogramins. So these are various higher class of antibiotic which can be given if you will have MRSA, but vancomycin is the usual standard first line drug of therapy. I want to tell you that these antibiotics, vancomycin and other higher class of antibiotics, these are important only when you have serious infection. Suppose if you have non-serious infection, due to MRSA, then you try to explore the other class of antibiotic other than beta-lactam, other class of antibiotics. Among them, the first line antibiotic you can try to explore. You can start with doxycycline. You can also go for cotrimoxazole. Okay, quinolones like levofloxacin. So these are various other class of antibiotics, the first line antibiotics, which can be explored if you have non-serious MRSA infection. Okay, so now we will discuss non-serious MRSA infection. Okay, so now we'll see what are the control measures which can be taken. MRSA can rapidly spread from in the hospital from one patient to the other patient through the contaminated hands of healthcare worker. So the hands of healthcare worker is the most common vehicle which will transmit the infection from one patient to other patient in the hospital. So please remember frequent hand wash. The most important way to contain the MRSA spread in hospital by frequent hand wash and use of other barrier precautions, especially the contact precautions can be used, like for example use of PPE such as gloves and gowns when you handle MRSA cases, and also you can have a travel restriction. Restrict the visitors which will which will be coming to the hospital, because they may carry MRSA strains. If they touch the patient, they may carry the MRSA, and they can spread in the community also. So you can have a restriction of the travelers, of visitors. You can also have dedicated patient specific dedicated equipment. Okay, like for example, the stethoscope, the BP apparatus, the thermometer, all these you can keep for MRSA patients. You can't you should not uh, cross use between the patient. You can dedicatedly, you can reserve them only for MRSA patients. So this is called as patient specific use of dedicated equipment. So these are the various methods to control the MRSA infection. Now we will move on to another important drug resistance called as VRSA and VISA, that is resistance to vancomycin. Okay, there are two type of resistance to vancomycin. VRSA stands for vancomycin resistant Staph aureus, and VISA stands for vancomycin intermediate Staph aureus. So these are important terminologies which you have to remember. So why vancomycin resistance will take place? Because of increased use of vancomycin, overuse of vancomycin. Vancomycin should only be reserved for MRSA strains of Staph aureus. You should not use vancomycin empirically, or even you know that it is a culture proven MSSA strains of Staph aureus. If you wrongly use vancomycin, if you overuse vancomycin for all this situation, then that leads to emergence of resistance. So please remember, vancomycin has to be preserved only for the MRSA strains, not for the routine treatment for Staphylococcus aureus. Okay, so the alternative of vancomycin needs to be okay. So now we'll see what. So now we'll see how will you treat so now we will see how will you treat VRSA and VISA infections. So when you have VRSA and VISA, you should consider alternative vancomycin for treatment, like linezolid, okay, streptogarmin, what we have discussed, like your quinupristin and dalfopristin. You can also go for daptomycin. Okay, so these are the various drugs which can be given for treatment of VRSA and VISA infection. But please remember that the mechanism of VRSA and VISA are different. Vancomycin resistant Staph aureus and vancomycin intermediate Staph aureus, they vary from each other in their MICs. If the MIC is more than 16 microgram per ml, then it is considered as a VRSA. If the MIC is 4 to 8 microgram per ml, then it is considered as VISA. So VISA is a low level resistance, VRSA is a high level resistance to vancomycin. They vary in their mechanism. The mechanism of VRSA is due to Van gene mediated. Van gene mediation is the mechanism to VRSA, whereas VISA, the resistance is due to increased cell wall thickness, increase in the cell wall thickness. Now we'll see how they are spread. So please remember, VRSA is very rare. It is extremely rare, whereas VISA is more common than VRSA. In India, hardly any case reports are there for VRSA, but VISA we have reported from various places. So VISA is little bit more common than VRSA. However, vancomycin resistance is overall is very less in India as compared to the Western countries, especially America, where vancomycin resistance is more reported. Okay, how will you detect VRSA? The vancomycin resistance you can detect by performing MIC based detection method for checking the resistance to vancomycin. You can also go for Van gene detection. Okay, so treatment we have already discussed. You can look for alternate drug like linezolid and daptomycin, also you can look for streptogrammin. Okay, so now we will see coagulase negative staphylococcus infections. So the basic difference between Staphylococcus aureus, which is the most pathogenic species of staph, and other Staphylococcus species is by performing a coagulase test. Other Staphylococcus species are coagulase negative. They are usually the normal flora of your skin. Most of the coagulase negative staph are the skin normal flora. Among them, the most important, the most common organism is Staphylococcus epidermidis, and it is the most common normal flora of your skin among all Staphylococcus aureus. Sorry, among all Staphylococcus species, Staphylococcus epidermidis is the most common normal flora of human skin. Okay, however, they can cause infection in specific situations, especially if you have any plastic surfaces present inside the body, like for example in case of catheters, in case of central line. So if you have any devices, okay, like central line or even urinary catheters or even stitches, then what will happen is this organism is able to colonize and will be able to adhere because they produce biofilm. Staphylococcus epidermidis is known to produce biofilm over plastic surfaces, and by production of biofilm they will be colonizing, they will be adherent to the plastic surfaces, as a result of which they can cause infection. That is the reason why you remember Staphylococcus aureus for device related infection. It is known to cause a device related infection such as central line associated bloodstream infection, as well as it can cause stitch abscesses. It can cause stitch abscesses. It can also grow over the prosthetics, especially the heart valves, and it can cause prosthetic infective endocarditis. So when you have prosthetic cardiac valves, the Staphylococcus aureus can produce biofilm over those prosthetic valves and can cause infective endocarditis. It is the most common organism to cause prosthetic valve endocarditis. Okay, so these are the various infections produced by Staphylococcus epidermidis. Now we will discuss other Staphylococcus aureus. So now we will discuss other cons such as Staphylococcus saprophyticus. It is known to cause UTI in sexually active females, urinary tract infection, and Staphylococcus lugdunensis. It is also it is also one of the Staphylococcus species which can be a human pathogen. It is known to cause various infections such as skin and soft tissue infection, bacteremia, okay, endocarditis. So these are the various infections caused by Staphylococcus lugdunensis. Lugdunensis is also important for one more reason. It is also a Staphylococcus species that is positive for slide coagulase test. Okay, so now we will discuss a few MCQs. Which is the least preferred antibiotic for treatment of MSSA? If you have methicillin sensitive Staphylococcus aureus, please remember, do not give a vancomycin. Vancomycin is an inferior drug for MSSA. Always anti-staphylococcal penicillin like dicloxacillin or even cephalosporins also can be given for MSSA infections. The next question, all the following beta-lactam drugs can be given for MRSA except no beta-lactam antibiotic should be given for MRSA except 5th generation cephalosporin. So in this question, ceftaroline, ceftobiprole, ceftalozone, all these are example of 5th generation cephalosporin. So 5th generation cephalosporin can be given for MRSA infection, but all other beta-lactam drugs should not be given, including piperacillin tazobactam. So please remember, for MRSA infection, all beta-lactam antibiotics are contraindicated except fifth generation cephalosporin such as ceftaroline, ceftobiprole and ceftalozone. So now we have discussed various staphylococcal infections. We have discussed in detail about Staphylococcus aureus infections such as skin and soft tissue infection and various other system infections. Then we have discussed the laboratory diagnosis and treatment of Staphylococcus aureus in detail. Then we have discussed a very important topic about drug resistance in Staph aureus, that is MRSA. So please remember, MRSA can come as a short note in your exam. Staphylococcus aureus in general is important essay in your exam. And after that, we have summarized the coagulase negative Staphylococcus species. I hope you have understood the session. Thank you.